Okay, yes, you're in your practice session.
And it said recording in progress, so we are good.
Yeah, I guess they set it to automatically record rather than you having to hit record.
Okay.
And I had asked when we had that meeting with her as to where that would go. When I looked at the settings, it shows on the local computer. So you just may check that if you do get the recording, you send it to her. Maybe they have it set like to a setting that I just missed that it will go. Maybe they've programmed it to where it will go to one of theirs. I don't know. I don't know how they would do that, but
yeah,
you may just check if it does record onto your computer, which it'll go to a Zoom folder, if so, most likely.
Okay. Let me see. Where is this? Yep, I have that right here. I don't like that they should have centered that.
Yeah, it needs to be either up, it needs to be off to the side like ours is. Because you are the A.
I am. All right. I'm going to see if I'm going to shoot Susan an email. I've been doing my timesheet all day.
Hi, Maya.
Hi, Maya.
Hey, Tom. How are you?
Good. How are you doing?
Good. Hopefully my cat will simmer down here in a second. The hazards of the Zoom presentations.
Worst case, she might start making a lot of noise, just bring it on screen. Be like, sorry guys, my cat.
Has a lot to say about CSC advocacy. Yes.
And you got your slides and you're good to go?
I think so. I'm just going to kind of clear out all the other things so nothing jumps up when I'm sharing my screen here.
Oh, yeah.
Do that right.
Just taking care of some last minute business.
No worries. Maybe I'll just try the screen share, make sure everything is working okay.
Yeah, that would be great.
All right, I did just get that host disabled participant screen sharing again.
You did, okay. Let me go in and take care of that. All right, now you should be able to.
All right.
Okay, perfect.
Did that pop up? Yep.
Yep.
Excellent.
Tom, if you're gonna want me to spotlight, you'll probably have to change my access, because right now, and maybe it's just because we're in a session or in a practice, but right now I'm not able to spotlight.
So I'm going to make you a co-host.
Mm-hmm.
Okay. Yes. Okay. So far, we have no attendees in the waiting room.
It shows
10-minute crucial window.
Right.
Yeah, I think y'all had like 92 registered the last time I looked.
Yeah, there was quite a bit.
Good. How have the sessions been going so far? You guys involved in the other ones?
So I've been participating in them. They're really good. I mean, really good, informative session so far.
Good.
Okay.
Mm-hmm.
Okay. That one's done. Knocking that email out of the ballpark now. What other one can I get done? And we still don't have the captioner.
And that'll be Patty today.
Yeah.
I'm going to email Asim too, just make sure he's not having any technical difficulty.
Which I didn't add Patty as a panelist. So you may need to add her as a panelist so that she can hop on the practice.
How do I do that? I don't see her name in there.
Okay. Let me, so if you go to zoom.us.
Okay.
And then you'll click on your webinar, not edit, click on the actual name of the webinar.
Mm-hmm.
If you scroll down to invitations on the bottom, you'll type in her email, which was Patty White.
So webinars, and then go down to
click the name of the webinar, and you'll scroll down, and there's a section that says invitations, I believe is the title of it.
Copy and send invitation to me. No.
There should be there'll be a part where it says panelists, like to send it to attendee as a panelist.
Nope. Nope. Either copy invitation or send invitation to me. This might be her. Hello, this is Tom. Hi. Yes. I am not seeing you. Let me see. What is your okay, what is your email address? And I will send it over to you. Okay. So I have pattycaptions@gmail.com. Okay. Let me see. You should be getting it right now. Right. I hope I did it right. I didn't invite all the attendees.
No, it'll have to be as a panelist for her to be able to get in the practice session. Worst case, we can add it.
Yeah, I invited you as a panelist. Yes. Is it PATTY? Yep, CAP. Yeah, CAPTIONS. Yep, at gmail.com. Okay. All right, thanks. Okay, bye. Well, that was fun. I learned something new. There she is. Hey, Asim, how are you? And there's Kwamina.
I'm good. How are you?
I am doing well. Thank you.
Can you hear me okay?
Yes.
Okay.
Hey, Kwamina.
Hey there. Sorry I'm running late.
You're okay. You're not a problem.
Mhm.
So the stream text link.
So that
There it is.
Yeah, that is going to be for the captions if they want them live, rather than hitting a CC.
So what do I need to do with that?
You can when people come in, you can just redrop in the chat. Did you give her the token to do the CC? That's where you'll hit the 3 dots.
Did I, Patty?
Nope, I still need that.
Apply the token. There you go.
Yeah. We should have just done it where I logged in as NARPA.
I know.
I'm not seeing that.
It says copy this token and paste the third party. Okay.
Oh, no, you actually have to assign me to
Gotcha.
do closed captions.
Yeah.
I'm
If you'll
going
hit
to
the 3
assign
dots on her name.
Patty.
Yeah, click on my name, the 3 dots on
Come
my
on,
name.
assign to type closed caption. There you go.
There you go. That's it. Yay. Got it.
Okay, so you're set.
I am set.
Okay, and so when we begin, I will drop, so we'll start when we let people come in. Kwamina, you're up first.
Okay.
And do the welcome, and then I will jump in and do the housekeeping, and let people know about captioning, let people know about Q&A, and that questions will be answered throughout the presentation. And then for chatting with various attendees, they can do that in the chat box. And then I will drop the link for the captioning in the chat box for folks to follow along with. And then I will introduce Asim and Maya, and then I will turn it over to Asim to begin the presentation.
Great.
Does that work?
Sounds
Okay.
great.
And then Lainey's going to handle all the spotlighting and stuff because that's too much multitasking for me. It's good
And
to
for
recognize.
questions, it's very hard to present and follow them. So will one of you guys just be chiming in if a question pops up?
Yes.
Yeah, we can if that's how you want us to.
Yeah, that'd probably be easiest.
And then Tom, are you going to drop the those links that we talked about in the session, or do I need to?
The captioning link.
On their slides, excuse me, on their slides, they had a
yes.
couple links that need to get dropped into the chat.
That's right on page 34 and 30. Yes. Do you want to do that, Lainey?
I can.
Okay.
I've got it pulled up.
Okay, good. And so I'm looking at the participants. We have 6 panelists and 0 attendees. Do I need to do anything? Did I do something wrong?
No, it's because you're in the practice.
Oh, okay.
Yeah, you're in the practice session. You're fine.
Lainey, is my lighting still okay? I feel like it's
Your face is really, oh, it's Kwamina. Sorry, I was looking at Asim. Asim's face is pretty dark. Kwamina, you're good.
okay.
Maya, you're good. Tom, you're good as well.
Yeah, I'm trying to adjust my camera, but I have a really big window
It might be
behind
the
me. So,
backlighting.
yeah,
Close the blinds. That might help with the backlighting.
I don't have blinds. Those
Oh.
are shades on the outside.
Wow.
Oh,
Okay. That Arizona weather. It just needs to be cloudy.
Yes. Got the mystique of looking like one of those, you know, documentary anonymized interviewees or something.
I have to talk with JJ about getting you some blinds or shades or something on the inside.
Yeah.
So are you in the Phoenix office, Asim, or Tucson?
I'm in Phoenix.
Okay.
Yeah.
You're in Tucson, right?
Yeah.
Okay. Okay. So I have 1 o'clock. Are we good to go?
you're good. And I would go ahead and hit start. When you hit start, just, you know, you might give it, you acknowledge, hey, we're here. Maybe give it like a minute to let
Okay.
people log on. That's what I would recommend.
Okay. I'm gonna hit start.
And then I'll jump in.
Turn my video off.
Okay.
Good afternoon. Good afternoon. On behalf of the National Association for Rights Protection and Advocacy, also abbreviated as NARPA, I am pleased to invite you and welcome you to the 3rd installment of our 2021 webinar series. This presentation is entitled Advocating for Equitable Healthcare in a Public Health Emergency. First, I want to thank the folks at Disability Rights Arkansas for hosting this webinar. NARPA feels fortunate anytime we have an opportunity to collaborate with protection and advocacy agencies throughout the United States. In particular, the partnership we've established thus far for the agencies that are now allowing these webinar series to be rolled out are now reaching a national audience even larger than the viewership we had for last year. So thank you very much. Thanks also to all of you who registered to participate in one or all of the webinars in our fall series. As the president of the board of directors, I'm honored to be part of an organization that not only talks about, but also walks out a commitment to people with psychiatric diagnoses. As I always say, we are proud that in spite of the pandemic and the cancellation of last year's face-to-face conference, we continue to walk out our mission of educating, empowering, and encouraging advocates who work with and for people with psychiatric diagnoses. Today's presentation is just another installment in a series that furthers our goal of supporting the legal and human rights of people with psychiatric diagnoses. This presentation, as well as all of the others, will ultimately be available on NARPA's YouTube channel. So thank you in advance to all of you who will watch them again and share the links far and wide. And with that, it's my pleasure to introduce Tom Nassau, Executive Director of Disability Rights, Arkansas.
Good afternoon, everybody, and thank you, Kwamina, for the introduction. We're really excited about the presentation today. Our two presenters are ready to move forward and talk about their presentation. But before we do that, I want to take care of a couple housekeeping items for you. For those, we do have I did paste the captioning link in the chat box, so feel free to open up that and follow along via captioning if you so choose. Secondly, the presenters are available to answer questions throughout the presentation. If you do have a question, please drop your question in the Q&A box below, and we will relay that to the presenters and they'll be able to answer your question. Secondly, we'd ask that you use the chat feature to interact with other attendees throughout the presentation. And with that, I'm going to introduce our presenters today. First, we have Asim Dietrich, who is a staff attorney at the Arizona Center for Disability Law. He's been there since 2011. He advocates for the legal rights of individuals with various disabilities. His work includes the representation of individuals who have experienced discrimination due to their disability, and the representation of individuals who've been denied medical and mental health care services. He currently serves as the coordinator of the organization's Abuse and Neglect Investigation and Monitoring Program. He's also the coordinator of the Protection and Advocacy for Individuals with Mental Illness program at the organization. Asim was admitted to the State Bar of Arizona in 2010 after earning his law degree from the Sandra Day O'Connor College of Law at Arizona State University. Second, we have Maya Abella, who's a supervisory attorney in the Tucson office of the Arizona Center for Disability Law. She joined the Arizona Center for Disability Law in 2015. She's assisted clients with various disabilities to promote and protect their legal rights to independence, justice, and equality. She presently serves as coordinator of the organization's Protection and Advocacy for Assistive Technology program. So those are our two presenters today. And with that, I'm going to turn it over to Asim, who will begin the presentation. Asim?
Okay, thank you for that introduction, Tom. So I'll start off today's presentation advocating for equitable healthcare in a public health emergency. Next slide, please. Okay, and I'm just going to start off with a brief description of who ACDL is and what we do. So we are a nonprofit law firm that assists Arizonans with disabilities to promote and protect their legal rights to independence, justice, and equality. And we envision a society where people with disabilities enjoy full acceptance without barriers. And ACDL is also the protection advocacy agency for Arizonans with disabilities. So we work to enforce the rights of people with disabilities to be free from abuse and neglect, discrimination, and other rights violations. Next slide, please. So the learning objectives for today. First, we're going to discuss and define crisis standards of care, what they are and how they operate, and then discuss non-discrimination laws as they're applied to the provision of healthcare, and then ACDL's advocacy efforts and where are we now? Next slide, please. So we'll start with a discussion of crisis standards of care. So crisis standards of care, or CSCs, as they're often referred to, are a plan developed by state public health authorities to provide guidance on the allocation of scarce healthcare resources during a public health emergency. So CSCs are implemented when the need for healthcare resources is greater than the availability of healthcare resources. So when the need exceeds the availability of these resources, CSCs are implemented to assist healthcare providers in determining what kind of care their patients receive. So it basically lays out a triage process developed by state authorities. So the Arizona CSC was developed by the Arizona Department of Health Services, which is Arizona's state public health agency. Next slide, please. So currently, we have the third edition of the Arizona CSC. So it was updated in 2020, just at the very beginning of the COVID-19 pandemic. The CSC was actually updated, and it provides guidance on the activation, operation, and demobilization of the State Disaster Medical Advisory Committee, or SDMAC. So the CSC provides guidance to this committee to consider developing incident-specific guidance. So the crisis standards of care basically provide the general guidance to the State Disaster Medical Advisory Committee on various considerations that should be included and discussed when responding to a public health emergency. So based on the guidance provided in the CSC, that Medical Advisory Committee developed incident-specific guidance related specifically to the COVID-19 pandemic. So it includes triage guidelines and considerations for healthcare facilities. So again, this guidance and these guidelines only need to be followed if the available healthcare resource or the available healthcare resources cannot meet the need for healthcare. So these guidelines would be implemented in that situation. And then they also include strategies for using and allocating scarce healthcare resources. Next slide, please. So the CSC COVID-19 addendum was a document that was produced by the State Disaster Medical Advisory Committee. So they used the guidance provided in the third edition of the Arizona CSC plan and developed this COVID-19 addendum, which included the incident-specific guidance on triage if the need for healthcare exceeds resources during the pandemic. So ADHS activated the committee in March of 2020 after the COVID pandemic was officially declared a public health emergency. And the committee issued to healthcare facilities the COVID-19 addendum to the Crisis Standards of Care Plan with incident-specific triage guidelines in the event that healthcare needs exceed resources. So again, these guidelines would only come into effect when the healthcare needs did exceed the resources and the state was in a crisis level. Next slide, please. And so the implementation of the CSC and the COVID addendum was on June 29th, 2020. So on that date, ADHS activated the CSC as well as the COVID-19 addendum and authorized healthcare systems and hospitals to implement their rationing and triage protocols in the COVID-19 addendum in the event that available healthcare resources are exceeded by healthcare need. So the COVID-19 addendum actually required that if there is a crisis level in the state, as far as the needs exceeding resources, that every hospital in Arizona would declare the crisis level at the same time. So if in the event that the COVID-19 addendum would need to be implemented, it would be implemented by every hospital in Arizona all at once. So at the time of the initial implementation, the COVID-19 addendum to the crisis standards of care did include some provisions that violated non-discrimination laws and would allow healthcare providers to violate non-discrimination laws. Next slide, please.
So Asim, we do have a question, and if I can read it to you.
Sure.
Okay, so the question is, are you suggesting that each state has a CSC? Because in Connecticut, the state categorically refused to issue a statewide triage plan and left it up to state hospitals, or left it up to individual hospitals.
So we're basically just discussing what the process was in Arizona. So when referring to CSCs, we're referring to states that actually developed and issued crisis standards of care as guidelines. So I'm unaware of every state that did actually issue CSCs, but we're referring to those states that did issue the guidelines on a statewide basis.
Okay, thank you.
Okay, so this next section will talk about the non-discrimination laws applied to the provision of healthcare, and basically discuss what must be included in any crisis standards of care to make sure that they do not discriminate. So I'll start with the definition of disability. So under the Americans with Disabilities Act, it's physical or mental impairment that substantially limits one or more major life activities. And then major life activities could include things such as walking, breathing, seeing, speaking, hearing, caring for oneself, learning, relationships with others, and a number of other activities that occur in a person's daily life. Basically, the daily activities of an individual can be considered major life activities. So this is not by any means an exhaustive list, but just a few examples. And the major life activities can also include any operation of bodily functions. So it can include things such as respiration, circulation, the functions of the endocrine system, neurological functions, muscular functions, and other operations of bodily functions. So I've included the citation in the ADA where you can find this definition. And it's the same definition in Section 504 of the Rehabilitation Act, as well as Section 1557 of the Affordable Care Act. So all three statutes have that same definition. So Title II of the ADA covers public entities. So the activities of any state or local government or any department, agency, instrumentality of state or local government. So basically anything that a state or local government does can be covered under Title II of the ADA as an activity of a public entity. And then Section 504 only covers recipients of federal financial assistance. So that could include state agencies that receive Medicaid funds. So under this, a public health authority basically would be covered as a public entity under Title II of ADA because it's an instrumentality of state government and also does receive financial assistance through the federal Medicaid program. Next slide, please. So these are some of the requirements of Title II of the ADA, as well as Section 504. So similar requirements for public entities, as well as recipients of federal financial assistance. So public entities and recipients of federal financial assistance may not deny a qualified individual with a disability the benefits of the services, programs, or activities of a public entity because of the individual's disability. So basically, a person with disability cannot be denied the benefits of anything that a public entity or a recipient of federal financial assistance provides. They also may not aid or perpetuate discrimination against a qualified individual with a disability by providing significant assistance to an agency, organization, or person that discriminates on the basis of disability and providing any aid, benefit, or service to beneficiaries of the public entity's program. So basically, a public entity cannot work with another agency or organization and allow them or aid them in discriminating against people with disabilities. Next slide, please. And then some additional requirements. Covered entities may not limit a qualified individual with a disability in the enjoyment of any right, privilege, or opportunity enjoyed by others receiving this aid, benefit, or service. So this could arise under, in the case of crisis standards of care, if the public health authority is limiting a person with a disability to access the same level of healthcare service as someone without a disability in a similar position. They also cannot deny a qualified individual with a disability the opportunity to participate in services, programs, or activities that are not separate or different, despite the existence of permissibly separate or different programs or activities. So basically, this is a prohibition against segregation of persons with disabilities. So a person with a disability cannot be offered services that are separate or different from the services that those without disabilities receive. Next slide, please. And then covered entities may not directly or through contractual or other arrangements utilize criteria or other methods of administration that have the effect of subjecting individuals with disabilities to discrimination, that have the purpose or effect of defeating or substantially impairing accomplishment of the objectives of the public entities program with respect to individuals with disabilities, or that perpetuate the discrimination of another public entity if both public entities are subject to common administrative control or are agencies of the same state. So again, in the healthcare context, what this would mean is that a state cannot utilize crisis standards of care. Excuse me, my phone is ringing. Just 1 second.
And just a reminder for those, if you have a question for the presenters, you can put that in the question and answer box, or you can use the chat to interact with each other. So I just wanted to remind folks about those options. There you go. Okay, go ahead, Maya.
I was just gonna say, I don't know, maybe Asim, it's just a reminder he's still on mute.
Oh, yes, I just muted it to stop my phone from ringing. Sorry about that. Okay, so I can just continue. So yeah, basically, crisis standards of care that allows certain types of disability-based discrimination couldn't violate Title II of the ADA because it would be, the entity basically would be arranging into an arrangement or method of administration allowing private hospitals to discriminate based upon disability. So it would be through a contractual or other arrangement, a policy that would have the effect of discriminating against people with disabilities. Next slide, please. And then covered entities must also make reasonable modifications in policies, practices, or procedures when the modifications are necessary to avoid discrimination on the basis of disability, unless the public entity can demonstrate that making the modifications would fundamentally alter the nature of the service, program, or activity. So unless providing reasonable modifications would fundamentally alter the nature of the service being provided, those modifications have to be provided. So things like modifying no animal policy in order to allow someone's service animal to accompany them when being admitted to a hospital, or in the context of COVID, modifying visitation restrictions to allow a caregiver or family member to assist a patient with their daily activities. Those types of things could be reasonable modifications because they're not fundamentally altering the nature of a hospital services. Next slide, please. And then covered entities may not impose or apply eligibility criteria that screen out or tend to screen out an individual with a disability or any class of people with disabilities from fully and equally enjoying any service, program, or activity, unless such criteria can be shown to be necessary for the provision of the service, program, or activity being offered. So basically, again, in the context of crisis standards of care, so a public health agency cannot develop triage criteria in crisis standards of care that would screen out or tend to screen out an individual with a disability. So the language in a crisis standard of care doesn't even necessarily need to specifically and explicitly screen out people with disabilities, but if they apply certain eligibility criteria that would tend to screen out a person with a disability, that would violate Title II of the ADA, as well as Section 504 of the Rehab Act. Next slide, please. And then just a brief description of Section 1557 of the Affordable Care Act. So this is another non-discrimination law that can be applied in the healthcare context. Section 1557 prohibits discrimination on the basis of disability, race, color, national origin, sex, or age in healthcare programs and activities that receive federal funding. So this could include state agencies and private healthcare providers that receive Medicaid funding. So it could include, in Arizona's example, it could include ADHS, the state's public health authority. It could include our state Medicaid program, and that could also include private hospitals that accept Medicaid patients. So basic public health authorities as well as healthcare providers are covered under this prohibition on discrimination. So claims under section 1557 are based on the intersection of two or more of the protected classes. So a section 1557 claim can be raised if someone is discriminated against on the basis of disability and race, for example, or disability and age. So if it's two, two intersectional protected classes, an individual has a claim against a section 1557. And so what we did see with the Arizona COVID-19 addendum to the Arizona CSC was that it had the potential to discriminate based upon disability, race, as well as age, because it included many criteria related to long-term life expectancy. And statistics have shown that people with disabilities, racial minorities, and older people often have a much more difficult time accessing needed health care, and as such can have shorter life expectancies, especially with people with disabilities and communities of color. They often statistically have shorter life expectancies because of discrimination that already exists in healthcare. So this section could also apply to crisis standards of care that look at long-term life expectancy, because certain groups on a statistical basis may have a shorter life expectancy. Next slide, please. So just a discussion on discrimination in the Arizona CSC third edition, as well as the COVID-19 addendum, which was the first edition. So this was implemented early in the pandemic. I believe either March or April of 2020 is when the COVID-19 addendum first edition was actually issued. So these are the ways in which that original version violated non-discrimination laws. So the first thing was that the addendum, the COVID-19 addendum, included considerations of long-term mortality and the opportunity to experience life stages. So it required that if Arizona didn't ever get into a crisis level where healthcare needs exceeded resources, it would have required triage officers to make predictions about long-term survivability of up to 5 years and allocate treatment based upon these unreliable and biased assumptions. So basically requiring healthcare providers to predict whether someone is going to live for the next 5 years if they receive treatment for the illness for which they have been hospitalized. So very unreliable, and a criteria that invites providers' own subjective biases into the decision-making process. Next slide, please. So again, predicting long-term life expectancy is unreliable and reflects discriminatory attitudes and bias against people with disabilities. And people with disabilities often have a statistically shorter life expectancy precisely because they are denied care based upon assumptions related to quality of life and social worth. So people with disabilities already experience discrimination in accessing needed healthcare services, which is the reason why people with disabilities often have a shorter life expectancy. Next slide, please. And then it also included an improper reliance on assessment tools. So the COVID-19 addendum allowed for an improper reliance on assessment scoring tools without requiring reasonable modifications for disability-related traits. So these types of scoring tools, things like the SOFA, which is the sequential organ failure assessment, these types of tools are often used in triage to determine who should receive life-saving care and who should, for example, receive palliative care and not actually receive the same level of healthcare resources. So in a triage situation, improper reliance on these assessments could screen out people with disabilities from receiving care that they would otherwise be eligible for. So for example, assessment tools often include whether or not the lack of purposeful movement is present. So the lack of purposeful movement is a symptom of many mobility disabilities. And this would have given a person a lower score on an assessment tool and give them a lower priority for care unless assessment tools were modified. So basically, the assessment tools need to allow for reasonable or require reasonable modifications. For example, if someone lacks purposeful movement as a result of a disability, they should not get a lower score and be deprioritized for life-saving care. Next slide, please. And then the COVID-19 addendum did not ban considerations of resource intensity and duration of need. So without an explicit ban, the addendum allowed resource allocations to be based upon the amount and duration of needed resources. So, this would screen out people with disabilities who may require greater treatment resources for a longer period of time or long-term care services. And it also allowed a consideration of the past use of resources. So for example, if someone is under a Medicaid waiver to receive home and community-based services, so they receive, for example, let's say they receive 40 hours of attendant care a week to assist with their daily activities. The original version of the addendum allowed that to be a consideration and allowed healthcare providers basically to deny care if someone had used a greater amount of healthcare resources in the past or for a longer period of time, or even if someone, for example, had a neurological disorder or a neuromuscular illness that meant it would take longer for them to recover from an illness, whether it's COVID or another illness. Those individuals would have been screened out in a triage situation because there was no explicit ban on looking at resource intensity and duration of need. Next slide, please. And then the COVID-19 addendum also allowed considerations of pre-existing conditions. So the addendum did not contain any prohibition on triage officers considering existing medical conditions when allocating healthcare resources. So it allowed for assumptions based upon perceived health or diagnoses, such as existing respiratory illnesses, HIV, cancer, or heart disease. So the addendum as originally written would have allowed healthcare providers to deny individuals with some of these pre-existing healthcare conditions from receiving the same care that others without these conditions could receive. So this was another way that the addendum allowed for people with disabilities to be screened out of receiving life-saving health care. Next slide, please. And then the COVID-19 addendum also failed to require reasonable modifications in policies and procedures. So there was no requirement that auxiliary aids and services be provided to patients during the public health emergency. So basically no requirement that hospitals provide a sign language interpretation for individuals who are deaf and use American Sign Language. No requirement that documents be provided, consent documents or other documents be provided in a format that that would be accessible to individuals who are blind or low vision. So no requirement that those types of auxiliary aids and services be provided to access effective communication. And then there was also no requirement that visitation policies be modified to allow family or caregivers to visit individuals who need assistance with daily activities. So it was basically up to the provider and every specific hospital what type of visitation policies they would allow and whether they would make an accommodation for family members or caregivers. So that was not required either. Next slide, please. And then the COVID-19 addendum also had a failure to provide notice of appeal rights. So the addendum did not contain a requirement that patients and families be notified of the right to appeal triage decisions. Difficult decisions are made when a triage situation occurs as a result of a public health emergency. But it is standard practice to have an appeal process available to patients, families, and healthcare decision makers, basically to appeal any triage decision. And there was no requirement that patients and families be provided notice of their appeal rights in the original addendum. Next slide, please. Okay, so now I'll turn it over to Maya and for further discussion on ACDL's advocacy during the Arizona COVID crisis and the crisis standards of care.
Great, thank you, Asim, for laying all that out. And I think it really sets the stage as he just kind of summarized the substantive problems that we were seeing with the COVID-19 addendum to our crisis standards of care. In conjunction with that, we were also hearing, both in our community and through the P&A network about some really disturbing and concerning accounts of discrimination that was happening in other states around the country concerning decisions being made in medical triage during COVID-19. Just to share a couple examples, one was of a woman with an intellectual disability out in Oregon who was hospitalized for COVID-19 and needed a ventilator, but the hospital denied the ventilator for the stated reason that she had, quote, a low quality of life. And the medical provider also wrote out like do not resuscitate orders, do not intubate orders, and pressured the woman to sign the documents, even though she did not really understand what she would be signing. Same hospital also requested that the woman's group home fill out do not resuscitate orders for all its residents. The issue was really only resolved after somebody contacted Disability Rights Oregon, which is the P&A in Oregon, about the situation and obtained the woman's transfer to a different hospital that did provide her a ventilator as needed. But it was only after threatening a lawsuit. And there were other examples that were frankly equally serious and equally distressing to hear about. And we also got contacted directly from several people within the community here in Arizona that reached out to us through our intake process and were really concerned about how they would be prioritized for care as people with disabilities in the event that they had to be hospitalized during COVID-19. And one issue I'll go into a little more detail when I talk about some of the other advocacy that we did, but it was related to will I be denied a ventilator, or will my personal ventilator be reallocated potentially? And another was very concerned about her son, who had pretty significant disabilities, not being able to be accompanied by her or other caregivers that know him and would be able to help advocate for him. So we're hearing about these, and obviously, in addition to the substance of the problems that we were seeing in the COVID-19 addendum, wanted to take action. And so in early April, we actually, just ACDL, we sent a letter over to the Arizona Department of Health Services, and we also directed it to the director of the Division of Developmental Disabilities. And we asked basically that they take certain steps to prevent disability-based discrimination in response to the pandemic more broadly. And the letter was prompted by the fact that, as Asim had mentioned, in March, the director of Arizona Department of Health Services had sent a letter that basically activated the state disaster medical advisory committee to make those recommendations for developing guidance and delivery and allocation of medical resources in response to COVID. So we were asking in that letter essentially for any guidance that is promulgated or pushed out as a result of this activating the committee, that they consider both the unique conditions in psychiatric facilities within Arizona, and provide the concrete steps that those facilities have to take in order to ensure the well-being of residents with mental health disabilities during the pandemic. And we also asked that ADHS, the Department of Health Services, coordinate with the Division of Developmental Disabilities to ensure that facilities and group living arrangements such as group homes that serve people with developmental disabilities also would have the guidance and the resources necessary to appropriately respond to the pandemic. We didn't get a response to that letter in April. And however, in June, when the Department of Health Services issued an update to the COVID-19 addendum, it did address a couple of those issues that we raised. However, there were still some significant problems with the addendum as we saw them. It still allowed for that long-term life expectancy to be considered, and for the opportunity to experience what they called life stages. And those were still being allowed to be used as factors in allocation of medical resources. And as Asim had pointed out earlier, these factors discriminate against older adults and many people with disabilities, and they're also more likely to lead to discrimination against individuals from communities of color as well. And the addendum still failed to prohibit illegal decision-making considerations such as intensity and duration of need of, and also the pre-existing medical conditions when they were considering allocation of life-saving treatment. And they also didn't address the reasonable modifications or the requirement to provide auxiliary aids and services that Asim had just mentioned, and also did not address the need for modifications to no visitation policies and those sorts of things that would be necessary to provide appropriate accommodations for people with disabilities if they were to be hospitalized due to COVID. And so because the CSC and the addendum at that point in time still contained these various provisions that would allow for disability-based discrimination and discrimination based on other protected classes, ACDL and also several other Arizona-based organizations sent another joint letter to ADHS in late June, on June 23rd, basically setting out our concerns, continued concerns with the COVID-19 addendum, and requested a conference call with the governor's office and the director of health services. We had that call in early July, and it was productive. We did feel like they were at least listening to the concerns that we were raising, and did some advocacy following up regarding that, basically providing them with language that we thought would be an appropriate substitution to ensure that what was memorialized in the addendum was not discriminatory and comported with non-discrimination laws. We we got them to agree to at least review what we were going to send over. So we sent that over and asked for a pretty short response time, because at this point in July of 2020, things in Arizona were pretty bad in terms of our COVID numbers. There was a high rate of transmission, and things were looking pretty dire. And so we had asked for a very quick turnaround. And we unfortunately did not hear back from them with regard to what we were suggesting be added or changed in terms of the language for the addendum. As a result of that, and again, due to the kind of increasing urgency here at the first wave of the first peak in the pandemic, we decided to move forward on preparing and filing a complaint, an administrative complaint with the U.S. Department of Health and Human Services Office for Civil Rights, also known as OCR. So OCR is the office that's responsible for investigating and taking action to correct violations or problems under the ADA and Section 504, and then also some other civil rights statutes for entities that provide health services. The complaint that we eventually filed in mid-July was filed on behalf of two individual named complainants that had contacted ACDL, and also several other local advocacy organizations, basically in the shoes of people with disabilities, older Arizonans, and Arizonans from communities of color who were at higher risk due to COVID-19. Our individual complainants were a young man with cerebral palsy whose mother and guardian had contacted ACDL to advocate on behalf of her son, and who was a person that is nonverbal, and who was concerned that basically he would be subject to discrimination under the current COVID-19 addendum if he were to need to be hospitalized and basically separated from her and his other caregivers that would be able to advocate on his behalf. Our other individual complainant in the complaint was a woman with muscular dystrophy who uses a ventilator in her daily life. And she was concerned that she would be subjected to discrimination if she were need to be hospitalized, and then also possibly denied life-saving care under the then existing, COVID-19 addendum, and also worried about her personal ventilator, which, was her personal property, being reallocated to somebody else, because at that point there was a pretty well-known lack of ventilators in the system. And so those were our individual complainants in the complaint. I would also mention, and I definitely want to emphasize, that we were joined on the complaint by ACLU of Arizona, and then also some other national organizations, including Center for Public Representation, Justice and Aging, the Bazelon Center for Mental Health Law, ARC of the United States, Disability Rights, Education and Defense Fund, and the Autistic Self-Advocacy Network. And really partnering with this large group of advocacy organizations was tremendously helpful. And several of them had already worked with other states' P&As concerning their crisis standards of care, and really brought a familiarity and some expertise with navigating the OCR technical assistance process that proved to be really invaluable in the advocacy that we did. So I won't get into too much of the detail in terms of the legal bases for our complaint, because actually Asim did an excellent job just sort of summarizing what they were. I mean, basically the claims were under the ADA, Section 504, Age Discrimination Act, Title VI, and the Affordable Care Act as well. And we affirmatively asked that OCR require our Department of Health Services to take a number of actions. We wanted them to prohibit healthcare decision-making that was based on long-term life expectancy for all the reasons that Asim described earlier. We also wanted them to prohibit decision-making based on intensity and duration of need, and require affirmatively that reasonable modifications to triage assessment scoring tools be made in order to not result in people with a disability getting scored lower as a result of their pre-existing disabilities. And we also wanted the Office of Civil Rights to prohibit decision-making based on pre-existing health conditions, and explicitly require that short-term survivability be the standard, and not looking at those long-term survival odds that are notoriously inaccurate and fraught with sort of the opportunity for internal biases to be entered into that decision making as well. And then also, again, reasonable modifications to visitation policies and communication auxiliary aids and services where needed to ensure that there's effective communication happening. We sent that, like I said, that complaint was submitted in mid-July. We didn't hear back from OCR or the Department of Health Services concerning the complaint. So we affirmatively reached out to the director of the Office of Civil Rights, asking for a substantive response to our complaint. We did that in basically like late October when we hadn't heard anything. We did hear back at the beginning of November, basically with a response that, you know, their position was their role was to provide states with what's called technical assistance. And they would be willing to do that, you know, provide that technical assistance concerning the CSC process. And at that time, basically, OCR was reviewing these complaints and saying, okay, well, we're either going to take it for investigation or we would provide technical assistance, which is essentially guidance on how to comply with the federal law at issue. And so when we didn't hear further from OCR on that, we decided we were going to go ahead and just affirmatively reach out to, again, the governor's office and Department of Health Services to discuss what we thought would, again, be the necessary changes following up on our complaint. And we had a conference call with them in mid-December, and we essentially, again, explained what the concerns that we were seeing with the current documents and why we believe that they violated federal law, and also affirmatively sent them examples of some of the other state crisis standards of care that had been updated and that had basically the appropriate non-discrimination language baked into it and included. And so we had that call, and then in that process, they also agreed to say that they were willing to engage in the technical assistance process with OCR. So we followed up with OCR in mid-December and formally requested that technical assistance be provided in order to get the office's sort of guidance on how the crisis standards of care could be updated to conform with federal law. We had a call with ADHS and our co-complainants and also OCR at the very end of December 2020. And after that, OCR provided the Department of Health Services with basically a technical assistance document, which outlined the changes to the CSC and the COVID-19 addendum that they believed were necessary to ensure that the documents complied with federal law, non-discrimination law. And we also got a copy of that document. And following that, we proposed some changes affirmatively. Again, we looked at the document, we looked at what we had already proposed, we made some recommendations to Department of Health Services of what changes could be incorporated to meet those technical assistance requirements. And basically had a process between January and March of, you know, negotiation back and forth on that language. One of the things that was a little bit of a sticking point for a while was that, again, we had been requiring that the triage be based only upon short-term survival considerations. And that was a little bit of a sticking point for a while, I think mostly due to kind of a misunderstanding of what the purpose of that was. We also had, during this time frame, Department of Health Services hire outside counsel. So we were kind of catching them up, bringing them up to speed on sort of the status of our discussions, the concepts that we were negotiating, and eventually we were able to convince the Department of Health Services to essentially adopt language that had already been approved by OCR in the crisis standards of care for Southern Texas. There was already a pre-approved. It was approved through the similar process, but earlier in time. They eventually agreed that they were willing to adopt that language. So that was incorporated into the CSC, and it was updated, and you can see the document at the link here on the slide. We sent it over to OCR that because it has to go through sort of an approval process, and they reviewed and eventually approved the changes that were being made. And the press release from OCR concerning the resolution of the complaint was this last link here that's also included on the slides. So we had, in addition to the administrative complaint, as we're going through this process, while the focus was really trying to get the updates made to the COVID-19 addendum to help protect the community and do it as quickly as possible to address sort of the current crisis. We did have this lingering concern of like, well, what if something slightly different happens next time? Like, what's the next public health crisis going to look like? Are we going to be, again, starting at the beginning, a mad scramble to do this lengthy negotiation process with the state to ensure that the rights of people with disabilities and other communities that are, discriminated against in provision of healthcare, essentially, are going to have to be brought into the process again late in the game, which is never ideal, and it unfortunately happens much more than it should. But we were looking for ways that, is there a way to avoid this in the future? We were approached by a policy organization that found a sponsor to a bill that would basically memorialize the essential non-discrimination principles that we were believing should be in every crisis standards of care sort of guidance document, not just the COVID-19 addendum, but basically things that were so fundamental they should be in all of the various iterations of these types of documents that could come in the future. And so we worked with that organization to try to get a bill developed, and we worked with them on the language, and eventually it resulted in House Bill 2386. It was originally a Senate bill, but it wound up moving forward under this House bill number, and it would basically the language required that any CSC or related documents such as the COVID-19 addendum would be adopted. Would specify these various requirements. So first and foremost, that each patient would be provided an individualized assessment. So basically the choice and the decisions regarding their healthcare would be made based on their individual situation. And then also that the person or their healthcare decision maker, if they had somebody appointed, would be the person to make those healthcare choices and have the right to an appeal for any triage decisions that they did not agree with. And then also that people could not be forced to sign do not resuscitate or making forced into any particular healthcare decision. And also that decisions about the allocation of healthcare resources were not going to discriminate on the basis of disability, age, race, religion, sex, veteran, or income status. So again, making sure that these fundamental principles are something that's going to be a part of any crisis standards of care document in the future. We also included in there that it would require that people with disabilities or older people also have reasonable accommodations to ensure that they get that equal access to medical care, whether it be a need for an auxiliary aid or service for communication disabilities, or people who might need a support person or a caregiver there to assist them with getting the medical care that they're entitled to. And then we also incorporated into the bill language that would require that healthcare providers consider only survival from the episode of care that they're receiving treatment for. So basically, again, it's not going to be made, the decision about whether somebody is going to get life-saving care is not going to be made on inappropriate and discriminatory factors such as perceived or actual disability, age, quality of life assessments, long-term mortality, life expectancy, need for resource intensity needs, or disability or age. And so we were, again, found these principles to be very fundamental and things that, based on whatever health crises that would come down the pipe in the future, thought that having this established in law as a requirement for any future CSCs would really provide a benefit to the community of not having to start over and start at the beginning in terms of ensuring that such documents take into account these considerations. And kind of one of the most fundamental, I think, pieces that I think will be beneficial as well is that we were able to essentially get a seat at the table for the State Disaster Medical Advisory Committee. So the law also required that the state P&A, which is ACDL, be a member of the committee that makes these decisions and develops these documents. And so again, we're hopeful that this can help be sure that the perspective of the disability community is considered from the beginning for future public health crises, and helps ensure that, if we need CSCs in the future, that they will at least be developed and include language that is non-discriminatory. So we were successful in getting that bill passed in the 2021 legislative session. It was signed by our governor at the beginning of July of this year, and will I was going to say it will take effect, but it took effect last week. So this is hot off the press, and is now in statute. The the citation for that statute is Arizona Revised Statute Section 36-791 is where that language now resides. So that is now law in Arizona. I did want to kind of conclude with a little bit of a reflection of, where are we now? Because obviously, while I think we know a lot more than we did last year at this time, the COVID-19 pandemic is still very much with us, and we're seeing, Delta variants and other things really throw a wrench in. I think what a lot of people were more optimistic at the beginning of the year might be something that we would see, the vaccines really be able to help eliminate. So I think one of the things that I wanted to reflect on is the fact that, this is the curve in Arizona, and this is 2020, and it shows a bit of 2021. It's not a completely current up to date, but I can tell you that our numbers as of August have maybe only come down very slightly. So you can kind of visualize where we were in October of 2020, and then where we are now in October of 2021, and our numbers are again quite high. It was really hard, I would say, engaging in this very long-term advocacy, to keep in mind that, this might be something that would still be as relevant now, or more relevant now than when we were initially concluding it. When we wrapped the complaint in April, and when the legislation was even passed in early July, there would kind of the question as to whether what we had achieved would be felt most for sort of the future public health crises, because the COVID-19 pandemic was looking like it might be winding down. But again, unfortunately, our numbers are back up there and pretty high again. And I think that just means that the work remains incredibly relevant. And so I just say thanks to, the incredibly helpful and dedicated collaborative partners that we had on these advocacy efforts. And, with a lot of persistence from everybody involved, we at least now have a COVID-19 addendum that is non-discriminatory, and that, we do have participation in the State Disaster Medical Advisory Committee that will hopefully help prevent these issues from becoming problems in the future. So just to kind of summarize lessons learned in terms of advocacy on this, collaborate as extensively as possible. There really was, I think in this circumstance and many others, strength in numbers in terms of the groups that got involved and were willing to help support us in this work and this really critical work. And also really benefited from having a wide network of connections. You know, if we didn't know somebody in some office, odds were high that somebody else did, and we could kind of work those connections to try to get meetings and other move things forward. And again, you know, as with all advocacy, I think in this area, just a lot of persistence and looking for more than one way to tackle the issue. So that's about it in terms of what we had for the presentation today. I just wanted to maybe open it up again, see if anybody had any questions.
So just a reminder, if you have any questions, you can enter those in the Q&A portion on your screen, or feel free to type those into the chat box. And I'm not seeing any questions come in.
All right.
If there are no questions, I just want to thank Asim and Maya for some great information and great work that you're doing in Arizona. And hopefully we can replicate the information across the country. And thank you for being part of the NARPA webinar series. We certainly appreciate all the work that you're doing. And for all of you out there listening, thank you for participating. The PowerPoint will be available after this presentation, I believe, on the NARPA website. And you will also get an email for registering for the training. So if there, last call for any questions or comments. Okay. Well, thank you again, everybody, for participating. And Maya and Asim, thank you so much. We appreciate all that you're doing.
Thank you.
Thank you,
Thank
Tom.
you.